Good afternoon, and welcome to the panel on Does Good Patient Care Demand the Human Touch? And we have three very distinguished panelists to share with you some of the novel technologies that are being used today in terms of healthcare intervention. And the format we're going to use today, I'm going to go ahead and do a little introduction, and we want to try to preserve as much time as we can for two things. One, for the speakers to go ahead and give their demos and talk about what they do, and also to give you a chance to ask them questions. So the format will be that I'll do the introduction. We'll let each of the panelists give a quick introduction in terms of the technology. And then also we'll ask some initial questions to get the question and answering session going. Then we're going to go to the audience to get some additional questions from you. So to get us started, the whole area of healthcare, while the change in demographics we've been talking about drives healthcare, what gets me most excited about the healthcare landscape is that there's never been as many diverse, sophisticated technologies coming into healthcare. And in Massachusetts, we're particularly privileged in the sense, if you look across the country, and some of the affiliations that we have internationally, that we actually cover a pretty broad landscape. And I think only the Bay Area can say that. We cover devices, we cover therapeutics, we cover diagnostics, we cover DNA sequencing, the chemistry and biology in Kendall Square at UMass, et cetera. And that creates very exciting opportunities in terms of research. And also, related to research, we're one of the most endowed areas in terms of federal funding, top 5 NIH-funded hospitals, #1 per capita in terms of SBIR funding, and we're also #1 per capita in terms of venture capital funding, but not #1 overall. So what I wanted to do this morning is to first start off to tell you a little bit about what my organization does. In my most current role, I served as the head of the $1 billion initiative for the governor of Massachusetts, and that gave me an entree into something that was very interesting, if I can get this to, is that when companies get formed, the core of our work, companies usually have two problems from investors. One of them is that most companies need to be de-risked or actually made more institutional grade when they actually start up. So what we do here is we apply a lot of time-tested marketing and de-risking toolkits and methodologies that validate the technologies from concept into commercialization. The second part of that is this whole world of getting non-equity or non-dilutive financing. And it's not a presentation about Exeter today, but I'll just give you a couple of examples. These are some of the core activities of the entity, the de-risking technology, accessing both government and industry sources, and then providing some innovation program design and management. So we do work with a couple of trans-Pacific initiatives, a couple of initiatives in Europe, and we also work with some states like the state of Kentucky. And this is what it looks like. This is just an example of what the work we would do. So we have a 3-year agreement with the agencies of the government that fund the SBIR programs, primarily the Department of Defense, the NIH, and the NSF. And this is the portfolio of the last year that we've worked with different companies in diagnostics, therapeutics. There's a couple of e-health companies. And what we do is apply two principles to these companies. And the principles are is the less dilutive financing and then also the refundable financing in terms of tax credits. So that's enough about me. I want to now make an introduction to our panelists. We have with us Tim Bickmore, who's the Associate Professor of Computer and Information Science at Northeastern University, with a very strong pedigree in this area of relational agents, he'll talk a little bit more about, with his pedigree trained at the MIT Media Lab. We also have with us the CEO and founder, Tom Ryden from VGO Communications. He will talk about the use of robots in terms of healthcare. Was part of the iRobot evolution that you probably see in that the very strong consumer application, and he's going to talk about today how that same application could have application to healthcare. And then John Pedersen will talk to us as well about some of the technology he's doing in terms of workflow development and some of the developmental disability market. And those are our three speakers today. So what I'd like to do is first start with Mr. Bickmore and to tell us a little bit about relational agents and his work at Northeastern University.
Thank you. There we go. All right. So for those of you who missed my talk yesterday, I'll try to give it the 2-minute version of it. So basically, what we do in my lab in the Computer and Information Sciences College is simulate one-on-one face-to-face interaction between patients and providers, and then use this for health communication and automated health behavior change interventions. So the form of the interface is we simulate the provider that talks using synthetic speech and a dialogue engine that dynamically assembles what it's saying, and synchronize nonverbal behavior that's animated using things like hand gesture and facial displays of emotion and body posture shifts and so on. This is our virtual discharge nurse that we've used at Boston Medical Center that we wheel up bedside for a half-hour-long conversation with patients before they go home. So we've used this in a number of inpatient interventions. We've also done a number of interventions in preventive medicine, including a project with Partners Center for Connected Health a couple of years ago that was a virtual exercise coach. So I thought I'd just show you first couple minutes of a sample interaction with that virtual coach by way of a demo. So in this study, we gave participants pedometers, and they were asked to talk to the coach 3 times a week for 12 weeks.
So, is the weather still nice out there? That's wonderful. I hope you can get outside and enjoy the weather while doing some nice, refreshing exercise. How are you doing today? I am sorry to hear that. Tell me more about how you are feeling. How tired are you feeling? So you can still walk, right? That is a relief. Please get some rest. It's so important to take care of yourself. Okay. So, what is your favorite kind of food? American food. Yummy.
Okay, I think I'll stop it there. You get the idea. But that's the kind of interaction. We interleave social interaction with the therapeutic part of the system and what it's trying to do with patients. We've had about 1,000 patients use our systems now across a wide range of different kinds of health interventions. So with that, I'll...
I'm not sure where he put it. That's right. Actually, there we go. So I have a couple of slides, but rather than the slides, I thought I would actually show what our product is and put it up here on the stage. So this is our robotic telepresence device. It's a physical avatar. It's a robot that really just represents you in a remote location. So this robot can be anywhere. As long as you have a broadband internet connection, you can connect to it and you can control it. And it really allows you to do a lot of things. So right now, it is, let me just see if I can get somebody up on it. Well, I'm going to leave that for now. We can do a demonstration with a person making a call into it. But what it allows you to do, and what it allows in healthcare as an example, is it allows a doctor to be in multiple locations. Imagine this in a rural clinic and a doctor wants to call in. This physically represents the doctor. He has full control. He can go see patients. He can take pictures. He can turn lights on. He can speak to the patients. In another application, we're doing instruction in hospitals. So we have these in operating rooms, and people who are remote can drive in and actually monitor an operation, engage with the surgeons and watch what's going on. And we also have hospitals that are doing it with kind of outpatient care, or sending this robot home with patients after surgery to really give a presence to in the home of a doctor or nurse or caregiver. So rather than somebody thinking that there's a problem with their child who's just had surgery and they need to rush them back to the hospital, there's a doctor right there. And they can go and make a call to the doctor and ask to have a reference, or have the doctor take a look at the patient. So, and we have a full, I'm just going to see if someone's available so you can drive it. Of course, as soon as you do a demo, that's always the problem. You never want to do a demo. So the person who I was going to call is unavailable, but I can show that to you later, or that person's going to call in now. And then they have complete control. So physical type of avatar, low cost, something that can be put in patients' homes or in hospitals. All right, thanks.
Still there?
That's all right. We'll move on. Yeah.
So Johnny Pedersen will come up next, and he'll talk about his workflow solutions for the developmental disability market. And this product has actually been in use in about 3,500 caregivers on a daily basis. And he'll talk a little bit about the technology and one of the leading European software companies in terms of emerging growth right now.
Ladies and gentlemen, thank you for spending your afternoon with us. Just a quick introduction to Team Online, which is a leading European software company. We're servicing the providers that are helping people with developmental disabilities. It's not a robot, it's not Avatar, it is software, but it is changing the ways providers servicing people with developmental disabilities are working. And as you see in the healthcare sector, we are also changing the ways that we are working in the social care providers. It is a web-based management system that makes work, the planning, the reporting, the documentation, and especially the documentation of the effects and outputs more reliable, easier, and faster. Unlike the traditional use of the paper documentation, now more than 35,000 people are using this in Europe every day, and it makes information and documentation reports available all the time. The main focus is, though, also when we talk about the healthcare, is that you're able to document the effects, the outputs. I think we are very eager to document what's going on right now, but we want to use that data to document that we're actually making progress when we're working with some of the most vulnerable people in our society, people that might not have the mobility or the communication skills that we are used to using. So the whole discussions today is really going to focus on how we can use technology not as a substitute for personal care and personal contact from my perspective, but that you can use technology to eliminate errors, double work, miscommunication, misunderstandings, and in that aspect create better working conditions for staff and the people we are servicing. And that will create the benefit of using technology in the areas where it makes sense, but it will create more time for personal care, and that's actually our motto at Team Online. We create more time for care. Just a quick look so you can see how it looks in the real world. This is actually a live shot from our website. It is a client management file, so you got all the information about the clients or consumers that we prefer to call them, all their plans, what services and activities are we going to do, what kind of objectives and work plans do we have. We have all the assignments and care plans that we would have for each and every individual, and we will also have the whole recording and documentation involved in our system. But mostly important, it is that we use this information to create indicators of what's working and not working. In the sense, if we change the medication, what effect will it have on their activity level, or how well are they responding to new activities and new programs. So this is web-based, where everyone can come and see what they have to do. This is just an example of the front page for some of the staff that will be working with these 3 clients and some of the activities they will be running this day. We will have further possibilities to discuss, but the real thing is technology can create actually more time for care, more personal contact, which I think is the objective for all of us.
Thank you. Thank you, Johnny, for that presentation. So now we're going to start. You know, it's interesting if you look at the diversity of the types of companies. So it's interesting, you have an international company that started out in Denmark, I believe now is based in Arizona, is that correct? Yep. And then you have another company that really has its roots in consumer products in the iRobot, and now is transforming itself, or actually leveraging that technology and the capabilities of the technology into medicine. Then you have an academic medical center. So one of my first questions would be is, as you look at the providers looking at this, and they're looking to, of course, contain that cost of looking at new technology, how do you position it in terms of whether it's incremental, the return on investment? So when you talk to providers, what is it that makes them, maybe we'll start with Johnny, because I know that you've had both the European experience, you have a lot of clients. How did you position yourselves to be adopted with the end users?
We have for the last 9 months been present here in the States, and when we talk to the thousands and thousands of providers that are out there servicing more than 30 million people with a disability, and it's a growing market with 350,000 children born with autism every year, and having more and more people, unfortunately, ending up with Alzheimer. The one thing that everyone realizes is we are getting rate cuts, we are getting squeezed financially, and the only way we can get our work better is by streamlining, making our workflow more efficient, and actually cut out as much administration as possible to create tools that you can save time on miscommunication, looking for information, and communicating. Don't forget, we're working with people that are needing servicing 24/7, and so there's a lot of staff involved. There's a big turnover of staff, so just streamlining and digitalizing all the information and reporting and documentation is very important. But the most thing that we actually sell, the most important point, is the fact that politicians are starting asking questions. What are we getting for the money? $1.2 billion is spent here in Massachusetts on servicing people with developmental disabilities. Does that have an effect? Does it actually work? Are we doing something? What can we do to get more out of the money? Can we do it differently? And being able to document what you're doing and what works and doesn't work, that's a tool that the providers really need today and are willing to change paper documentation into digitalized information. And it works. It takes about a couple of weeks to implement it, and the return of investment is right there because you can save so much time on administration and supervising because you don't have physically to go out and see what's going on. You can online check what's going on.
And Thomas, before you answer, I had a chance, there was an article about the advances in medical robotics that was a cover story for Information Week, and what it said, and I'll just read it back to you, and I wanted to put that in context in terms of how you see the future of robotics being used in healthcare. The article, which came out in the first quarter of 2011, says, robots play a critical and growing role in modern medicine, from training the next generation of doctors, dentists, and nurses to comforting and protecting elderly patients in the early stages of dementia. Using robots, medical professionals can make smaller incisions for shorter surgeries, reducing hospital stays, and improving patients' prognosis and saving costs. As robots become even smaller and developers continue to further integrate the devices with artificial intelligence, the medical community will continuously expand the ways in which it uses this technology to save patients, improve quality of life, and prevent health problems. And that's the analysis that was done. They showed about 12 different advances in robotics, from a nurse bot to an IntelliFill pharmacy robot. There was all types of different applications. So I wanted to give you the chance to, comment in terms of what you see in the application of robots.
Sure. I think everybody's kind of aware of the development of robotics across the fields, as you mentioned, Louise. Everything from robotic surgery, which is certainly an amazing development, to products like this and other products that can extend the care. When we talk to providers, they're really looking about what ways can they make themselves more efficient. Technology like this is not going to replace a doctor or a nurse anytime soon. I think what you'll see is that the robotics will aid and assist nurses and doctors in doing their chores and kind of alleviating some of maybe the heavy-duty lifting of a nurse to being able to lift patients and move patients. You'll see robots now that assist in hospitals that make the operations more efficient, whether it's moving food and laundry and so forth around the hospital autonomously, to products like this which extend the care of doctors and nurses, allowing them to be in multiple places. So I think it's really about looking at how this technology can make the doctors more efficient and reduce their costs. And the technology is evolving very rapidly. This product has been out for less than a year. I think you'll see in the next couple of years, you're going to see a lot of technology that utilizes robotics to really and to start to come to fruition in the healthcare market.
And how about you, Tim, in terms of the relational agents? I know we talked before, and there's some confusion whether it's avatars, relational agents, Second Life, but you seem to have been able to attract a tremendous amount of research support as well as customers in this area. And if you could talk about what is it that the providers see in the relational agents, and what is it that you're developing for future applications?
So I've been focused more on health outcomes and the patient experience and really focusing on that. And as Tom said, also not trying to ever replace providers, but to augment what they can do by automating routine tasks, intervening with patients in contexts in which providers just aren't available.
So a couple of applications you on your research that you have a lot of different applications. The nurse assistant, you have applications for adherence and compliance. Which one of the applications do you see that the providers get most excited about, and the ones that resound mostly with them?
Well, the Bedside virtual discharge nurse is a product that we've licensed to a startup about a year ago, and seems there's a lot of focus right now on reducing 30-day hospital readmission rates. So that's a driver for that particular application that's made it receive a lot of attention.
So I wonder if any of you could comment, when you look at some of these applications, they obviously have a lot of benefit to the consumer. All of them do. Do you perceive that perhaps consumers should perhaps be incurring some of the costs associated with having these technologies? Do you foresee that as being part of the possible adoption of it?
I think the most important thing here is to acknowledge the change is necessary. It's because the cost of any servicing at the hospitals or at providers servicing people with disabilities or at homes where we are supplying services at home for patients or for people with disabilities, the cost will keep growing. And if we don't make changes like this, it's going to be the battle between whether it's insurance companies, politicians, or own pay. You will see in my field that it has always been paid by the different states here in the country, but bottom line is private pay is sneaking in too, because if you want to increase the service level, you will have to either increase the efficiency by technologies and services that are based on software solutions or robotics in order to cut the cost down, and by that increasing service at the same time. Otherwise, we will have to pay even as private consumers.
I think one of the things that on products like this and other robotics, you're going to continue to see the cost decrease. And so there'll be other applications that will open up, certainly in the consumer side. We look at elder care as a potential example of whether you could have a physical avatar in your home and really allow a presence there that maybe someone wants to live at home longer alone, and yet you don't feel comfortable having that person be unattended. Maybe technology like this will allow them to do that, to have somebody who can come in and check up. But to be able to do that, we have to get to price points that people can afford to buy it and purchase it in their home. And so I think if you look at how technology has gone, if you look at what a plasma TV was a few years ago to what it is today, I think you're going to see that same type of kind of cost decrease in robotics in some of the technology that you're seeing discussed today.
So a little quickly on cost, and then we're going to go to the audience and get some questions. So what would it cost an institution to have each one of your products? I guess in your case, Johnny, you probably want some type of a enterprise level, some type of subscription minimum. But so what would it cost? What's the cost of it?
Well, it's very simple. We have a user fee, a monthly service fee, $15 per staff that are using the software. So it's a very minimal cost when you look at how much administrative cost you can be saving. And I think that's all about technology. If you see technology as an investment, as a tool to make you more efficient, then you will just basically have to look at the return of investment, how fast it's going to go. But most people will see software, computers, technology as a new cost on top of already existing cost. And I think that's the change of mindset that we all have to work on, that robotics is not an extra cost. It's not a new cost. It's an investment in making your workflow and your operation more efficient. And in that way, it's going to reduce cost. And I think we often forget that this is also a matter of changing the workflow. I mean, 10% of what we do is changing technology, but 90% is changing the workflow. We don't need supervisors to physically go out and check what's going on. They can sit at home checking whether the jobs are being done that we have promised the disabled. So often technology is seen as the whole thing. That's a cost, extra cost. But for me, it's really a tool to change the way you're operating. It's not just doing the same thing over and over, just not with robotics. It is a tool to change the whole workflow at your institutions, your hospital, or your facilities as I'm working in.
So the cost of a robot like that is about $6,000. So probably a little bit too much for a consumer, but certainly an affordable piece of equipment. But what the real benefit here is if you look at some of the applications that they're doing and what they believe, what doctors believe the return on investment can be. In the discharge example that I was using, when they view their major expenses as readmissions. So if we can put a device like this in a patient's home for a couple of weeks, if it eliminates one readmission, it pays for itself. And it's a shared device. You can use it amongst multiple patients. So really the cost per visit is quite low.
Yeah, and our agents are software only, so if they're deployed in an intervention in which we have dedicated use devices, then it's whatever the cost of the tablet computer is. But otherwise, if it's on somebody's home computer, then it's just marginal server fees. So.
And your particular technologies, Tim and John, do they work on the cloud, or they work on how do they work on mobile applications and the cloud environment?
I think we're really seeing a revolution here where every software is becoming software as a service. It's not something you install a computer. It's going to be web-based because you basically have to have access to it at all times from anywhere. And with the 4G coming in and changing the whole format here, I can only say that imagine the difference between having the information in a binder at one of these group homes and you have to go and get it. And now you have it available on my smartphone here or on the tab out there or on the computer at the doctor's office. They can go and check what's happened. That is, of course, just a solution that everything needs to be available from everywhere, from any instrument that you can access the web on.
Great. Well, thank you. And we now want to turn to the audience. If perhaps you could state your name and the entity you're affiliated with and ask your question. I believe there are microphones out there somewhere. Is there someone with a microphone? No? Okay. So I'll either speak up or I'll give you a microphone from one of us. Some questions?
I'm interested in the design process that you've used for the virtual nurse and the choices of your team to in the aesthetics or the presence of the nurse and its human relatability, why it has a computer voice, why it's a flat cartoon rather than a 3D animation, or why it's not a human that's just recorded on a video. What the advantage of your cartoon is.
Okay. So the synthetic speech and why we also are not using video is because the language is dynamically assembled from information in the patient's medical record, from the questions that they're asking, discourse context, if it's a longitudinal interventions, what was said in prior conversations, data from their pedometer. So all these things go into sort of making a dynamic unfolding conversation. It's not scripted or canned as a linear speech. So even doing interleaved video clips, you'd have to have an enormous number of clips to do that. As far as the 2D rendering, we originally started doing that because we wanted to deliver on very low-end platforms that didn't have graphics accelerators. That's not so much an issue today, but we've also found that actually the 2D cartoon characters keep us away from the uncanny valley, if you're familiar with that. So there's this notion that, or this effect that's been shown that as you get characters that get more and more photorealistic, look more and more human, people get very sensitive to small deficiencies, and they just look weird and really off-putting. So we avoid that by just having very simple characters. We only give them the features that we know how to animate based on studies of human-human communication, and we find that patients are very receptive to this form of interaction.
I think it's a very relevant question because I think the next generation coming are just being so much used to get all the information from a tablet or from a computer screen or TV. I know my own daughter, she knows more about what her friends are doing and eating at all the time with the Twitter and Facebook. She has that information 24/7. She actually gets confused when she gets information on a piece of paper or not in a format that has the colors and shapes and responding the way they used to. So I think the landscape of design is definitely changing because that paper format that we have been used to studying and working is going away. It's simply going online. So whether they're used to getting news clips before they actually happen or as they happen, that is just something we as developers clearly has to take into consideration when we're designing our software, our robotics, and how we share that information. It has to be a format that the new generation can relate to, because if we do it our way, then it won't relate to the next generation coming.
Games and people's relation to that, and how I don't know much about gaming or the relationships people have online, but the characters that I've seen are so developed, and they're not in the uncanny valley. They're real. They're relatable. They're programmable. They can still have the voice. I don't know. It's interesting to think about, and I'm curious about the design of these things.
And that's even a harder challenge with a physical product, because you can do very realistic robotics now. There's humanoids, they're physical robots that are very hard to tell apart from a human. But what does that value add? It's very expensive to do. It's very complex physically and mechanically, and that adds a lot of expense. So is that provide real benefit? Do people want to interact with a robot that really truly looks like a humanoid? We've gone a step the other way and saying, no, we don't want to look like a humanoid. And much like what Tim was talking about, the uncanny valley, understanding which side we want to fall on and how close do we want to get to that. So we've chosen a form factor that has a subtle look of a human, but is not a humanoid, and that was on purpose. But that's a great question. Where do people, is their expectations going to grow such that you have to develop in the future a full walking, talking humanoid to do any of these things?
And I do think that's a generation gap. I do think with elderly, we need to have one solution. And for children, even when it comes to education, they're used to being inspired by technology, by video, by movements, by stuff. So the old-fashioned way of teaching might not be relevant for them. But there's clearly a big group of elderly that are not comfortable with things looking too much science fiction and too much like a robot. That can clearly be a generation gap here that we have to take into consideration.
Although I'll say we've done lots of interventions now with geriatrics patients and presenting these cartoon-like providers to them, and they're very comfortable using them. So.
I'd kind of agree on that. We've done some trials with elderly, and they're more accepting of the product.
Yeah, great.
Because I think they look at the benefits and go, wow, does this let me stay at home longer? I don't care what it looks like in a sense. So.
And for me, they've been very receptive to the social aspects of the interaction. They really enjoy it.
If it came out that I think elderly are not ready for change, that's wrong.
You still chose a human form. You didn't choose a box that talks. But there's something to the empathic, relational, interpersonal thing that's happening, because you are looking at a human form, even though it's a flat computer-generated, obviously not a human. So, yeah, I don't know. I think there's definitely room for further design, or to consider more design and the psychological impacts of that.
We have another question in the back over there. Someone.
Hi there, my name is Howard Simpson. I'm from Brandeis University. So I'm wondering who is cleaning these robots as we trust these machines to operate more and more autonomously over the course of a hospital. They're rolling over whatever's on the floor without looking where they're stepping. They're being touched by all kinds of people, doing all kinds of things with gloves, without gloves. Who really knows where it was before it walked into or rolled into your room? And I'm really wondering, are there protocols being established alongside with the development and implementation of these devices to make sure that they're not transmitting disease or any other kinds of particles that could be dangerous that a human would, through training, realize to minimize the risk of?
So, that's a great question, and it's interesting. Not a lot of thought has been has kind of put into that on the healthcare side yet. On the military side, the whole idea of can a robot autonomously shoot has been an issue that has been raised and thought of, and more in what are now ground and humanoid types of robots. Who has control? Who has the ultimate control? Who can make that decision? How much of that decision can be made by the robot? So I think the military is really looking at those type of questions quite seriously and trying to figure out, as these things become more autonomous, have more AI in them, where is the boundary and what do we allow? In healthcare, that hasn't been raised, but those are great questions. Where is this environment, where has this been? What's the environment it's been in before? How is that going to impact the next patient it goes and sees? We don't really target so much in the hospital from going to patient as more as in a home where it can be used in that sense. But even there's the same type of questions. So I think the short answer to you is there's a lot of work that needs to be done in that area.
We have a question in the back and maybe over here.
So I just want to, I'm Cathy Decker with Partners Healthcare at Home, and I just want to go on the record that I want my robot to look like Jude Law or Hugh Jackman. But other than that, the real question is as we get into the avatars, has there been any study done with how do I say this politically, that we bring our own prejudices based on the avatar? So when you watch James Cameron's Avatar, they were blue, right? It's because blue was blue. And when you look at cartoons, they're green and purple and all different colors. And as we look at the use of avatars in care delivery, is there any thought in terms of that, racial disparities or cultural differences? Or
Yes.
So what's the long answer?
So let's see, what's the short answer on this? So we've done some studies on doing racial concordance, so matching the ethnicity of the character to see if that makes a difference. We've done some lab studies and shown that racial concordance does matter as far as being able to change the attitudes of patients much more than even linguistic concordance, so changing to the patient's first language, for example. But the results are very mixed. We've done other studies. We've done racial concordance sub-studies. In the virtual nurse, we had an African-American and a Caucasian character that we randomly assigned to patients and found that it made no difference in that particular context. So what we generally try to do, actually, is build characters that we consider to be racially ambiguous. and as you just said, patients generally infer that they're of their own race when they interact with them. And that seems to remove a lot of these issues.
Question up here.
Thank you. So I'm thinking about years I had of experience in home health with geriatric patients for physical therapy, and thinking about the robots and their application for home health and all of the functional decline and concern with falls and mobility and the like. So a very practical, perhaps easy question. This obviously moves on its own. And so my question is, in terms of the home application, is this meant to follow the patient? How do they get the device from one room to another and make sure that they don't trip and fall and so on?
Yeah, so in that particular application, this robot is not autonomous. So this is actually driven by someone on the remote end. So someone can actually go and find where that elderly patient is. But it is amazing in the technology that's being developed to assist people, kind of the exoskeletons. There's a number of companies right here in Massachusetts that are doing robotic prosthetics, whether it's ankles or legs or arms, and exercising and bringing mobility back so people who have stroke can add robotics to really teach their body again how to use certain extremities. I think those technologies are really coming along. Can you combine those with these, and it becomes a cost issue more than anything else?
I was actually thinking more along the lines of some of the environmental controls, for this application, not necessarily the functional, but there are for individuals with sip and puff wheelchairs, for example, and the technologies for communication boards, et cetera. So I was wondering if this was starting to be integrated in that type of technology that didn't require, so if someone had already some technology in their home, such as environmental controls to be at home, is this an application that can be added to that?
Yeah, so you can integrate with existing sensors. So if there are other sensors that tell you certain things about the environment, you can integrate that into the robot. And the robot has its own sensors to tell that other people are around, so it won't hit obstacles, it won't run into somebody who's there. But really it's what is the use case and how does that add value to that elderly patient? I think there is so much technology that can be put into homes. You have to be careful of what is the value for all of that being put in there, and how do people interact with it. So there's a lot of studies going on about how people interact with robots, both when they're present with the robot, and back to Cathy's question, what do they look like? How do they, we have one color. That's more because it's early on and we only produce in one color. But do people want to see it in different colors, different shapes, different sizes? People dress them up now, so we'll see a lot of robots that people will put stickers on or hats on or things like that to personalize it. We have a lot of these in schools, high schools, where they represent a student. Student's too ill to go to school, so the high school will buy it and put it in school, and they can attend it. And all of those get somehow dressed up. So what does it mean long term? What do people want them to look like? That's a great question as well.
I think it's a great question, and I think it's one of the areas that we really all need to focus on, because in my field you will see so many smart, intelligent solutions out there, from intelligent beds to intelligent bathrooms to kitchens that can do miracles for you, computer hardware where people without arms or legs or blind that are actually able to communicate in different ways. We have great communication tools, telemedicine, where you can communicate with your care providers and your doctors, your speech therapist. Everything can actually be done. You can have more independent living skills. You can stay home longer as elderly. There's so many tools out there, but the connectivity is just not there. It is separated solutions, and it's very hard to gather all that information and use it. They have to have 5 or 6 different solutions to actually live independently. And that connectivity, I think, is one of the discussion themes that I've heard over and over again. How do we make sure that you have 6 or 7 different solutions out there that we can sort of gather those information? And it is possible, because my TV, I can see that. I stop it in one room, go into the next one, it works. I can from home turn on my light and my heating and my air conditioning. I can fix that all. It's all related on one keyboard or one feature. And I think some of that is something we really need to put a lot more focus on to get all these wonderful solutions to work together and use that to actually document what's going on. Does it work, and what needs to be changed in order to create, for my independent living skills, or better social ability or mobility, et cetera, et cetera. And she's talking to me now.
Yeah.
Thank you for the insightful questions. It seems that the audience is really interested in design aspects of this, and very interested in how it integrates to normal environments, how it can integrate, how it can't. And it also seems to be a lot of interest in terms of what applications it actually could have far beyond what it's doing today. And I want to conclude on that theme. All the three of you are visionaries. You actually have technologies, both in your research and what you're doing today, that were far ahead of what the consumer saw. In a theme of Steve Jobs, and there was a great article in The Economist. He talked about how he did product design before you had passed, and he always felt that the customer really never knew what they wanted until they saw it. And I was wondering on that theme, if we could close on that, to say if we were to meet here 5 years from now, we were all here again, and everyone came back, what do you see your technologies in terms of adoption? Or what is it that's going to be different from today?
Wow. So I guess in my research, I take the exact opposite stance, which is we always start with a role model of a human provider who's a sort of gold standard that we're trying to emulate. And then we start off videotaping interactions between them and patients, and then try and replicate that as closely as we can. So we're trying to mimic real life and what people are already used to. So what's going to be in 5 years? So one of the areas we're pushing on is augmenting our agents with a lot of sensors. So I talked briefly about this yesterday. In the hospital environment, having a bedside virtual companion agent that's able to sense when providers walk in the room, identify who they are, introduce them to the patient, know when the patient's awake or asleep, so we can do sleep management, and have others have acoustic sensors, so it can know when device alarms go off and explain those to the patient. So just making the agents much more aware of what's going on in the environment, and then explaining that to the patient and helping to let them know what's going on with their care. So that's one of the directions we're moving in.
So there's so much going on in robotics. I think we're more constrained on getting things into products that make them available so people can use them. So if I look out 5 years or so, I see a whole host of autonomous behaviors and capabilities added to robotics. everything across the border from your car. Before you know it, you'll be able to get in your car and say, go to work, and it will go to work, and you don't have to drive. Whether people want that or not is another question, but that technology is very close to, and it's being deployed in some areas already, and a couple of states are now allowing that technology. To technology that will allow you to really have a humanoid that can do things for you, like fold laundry and help with a patient and lift the patient and move the patient and do all sorts of things all autonomously. That technology is coming. It's fascinating to watch, and I think you'll see some of that in the next 5 to 10 years.
In 5 years, we will have the reality of communication with your doctors and your hospitals and your care providers being online. In 5 years, we will see more and more of this technology coming into private homes so people can stay home longer and they can have independent living skills. We will also see a demand from the next generation that information about what's going on and the effect and output of what's being treated to them or given to them, it has to be online and accessible 24/7. And I hope that politicians will start seeing that technology is not a cost, it's an investment that will create better results and will save time, save money over time, and more importantly, that we, through prevention and effects documentation, can actually save a lot of money if we just do it right and we start investing and not just trying to fix problems by old solutions.
Great. Thank you, panelists. That concludes our session. Thank you for your great questions. I know you probably all know the Twitter feeds are pretty active on these sessions. These slides are being recorded. They'll be available. So the social media aspect of this presentation, you can follow it with you. You can check also on the blog and as well as the LinkedIn group that has some members. So there's a lot of activity that you can continue to follow this, and feel free to comment and post your thoughts as well. Thank you.